basic idea about these small videos is to introduce to you few of the clinical signs. We won't be going in depth about any of these entities. Today we'll learn visible peristalsis. This is a surgical problem. Once in a while we encounter surgical problems in pediatric case also. This is a newborn baby. Was born at term with adequate weight, was gaining weight with breastfeeding, very active. But after third week, around 26 days or so, mother noticed was having vomiting. Vomiting, regurgitation of feeds are common due to feeding problems. Proper burping is not done. Non-bile stain, but they will be gaining weight normally. But in this baby, vomiting increased and gradually he was not doing well, not gaining weight or losing weight. So he was brought here on 36th day. On the day of examination, he lost weight, he was dehydrated, and baby was eagerly sucking, feeding after the vomiting. One of the most important physical finding is to observe the vomitus. The vomitus was non-bile stain. It was milk. That means there is an organic problem because something which is producing weight loss, dehydration, we should consider organic problems. And milk was white. So we need to consider one of the commonest, very important entities in this age group, that is the congenital hypertrophic pyloric stenosis. The clinical signs which we need to look for are two. One is palpable mass under the right hypochondrium. It is a pear-like mass. It's very difficult to get that mass. You can imagine the difficulty of palpating an abdomen of a newborn. The moment you touch, it will go into rigidity. So ideal situation is to keep the baby feeding under the on the lap of the mother. You expose and palpate very carefully. You will get the mass. The next one is observation of the visible peristalsis. Now we will see what we saw. See, there is a interesting thing. There is a mass moving from the left to the right. Very clear. This is the direction of the movement, starting from the left to right. So that means it's from the stomach. The direction of the VP is very important in any case of intestinal obstruction. The small intestinal obstruction, the other intestinal obstruction, that gives an idea from which part this intestinal obstruction. So in this age group, when you get a visible peristalsis, there is an outlet obstruction. It can be in the pyloric area or can be in the duodenum also. So this is one of the classical findings. Very rarely we get this beautiful visible peristalsis in a newborn baby. And we could palpate the pear-like mass also. The interesting thing is, this visible peristalsis is observed while on feeding, but the pear-shaped mass is observable when, after a bout of vomiting, the baby, before we are restarting the feeding. Few points about a clinical scenario of a vomiting in a newborn. It can be simple benign regurgitation where the baby won't be affected, gaining weight normal, no other problems. When will you consider it's an organic problem? Organic problem again can be medical causes and surgical causes. So we need to consider these organic problems. If the vomitus is bile stained, the classical teaching is there is a surgical problem. The obsession is beyond the sphincter of body, there will be regurgitation and bile stained vomiting. And vomit is producing dehydration, vomit is producing shock, electrolyte imbalance, and acid base imbalance. It means it's an organic obstruction problem. And the baby is not gaining weight. So these are the situations where we need to investigate. It can be both medical or surgical causes. There are many medical causes, but when we consider surgical causes, very interesting. Where is obstruction? It can be a distal obstruction like a Hirschsprung disease, anorectal malformations, duplication ileum. It can be a jejunum. So when the distension, the distal the obstruction, more will be the distension, but the vomiting will be late. If it's a proximal obstruction, vomiting will be early. So in a case where the obstruction is up to the duodenum, the abdominal distension won't be much as in this case, but vomiting will be predominant. Very interesting thing, the classical teaching of the bile stained vomitus occurs beyond the sphincter of body. The bile enters here and the obstruction is here, bile stained obstruction. The obstruction is somewhere here. So the classical one is a CHPS, Congenital Hypertrophic Pyloric stenosis, where the obstruction is here, elongated, thickened pylorus. Or if some of the situations where it can be blocked here, you heard of malrotation. Malrotation produces an obstruction at this level. It can be a duodenal lattice here, it can be an annular pancreas and all. So in those situations, if obstruction is proximal to the sphincter of body, we will get a non-bile stain vomiting. So in this case, it was a non-bile stain vomiting. So in this case, what did we do? For the confirmation, the first level we took an X-ray. The interesting thing, see, there is not much of gas. In intestinal obstruction, we get distension of abdomen and multiple fluid levels, as is the cyst case. This is the classical situation of intestinal obstruction. Distension is the multiple fluid levels. This is a classical situation of an intestinal obstruction. But in our case, there was distension of the stomach only. Not even the double bubble. But the duodenal lattice, you will get a double bubble appearance. So in the stomach only is distension, not much of the gas in the other areas. And very important, we need to screen for other malformations. For the respiratory or a cardiac malformations, we need to screen because it can be associated. Now we see the abdominal patient. There is no distension. This is indicative of an upper GI obstruction. Now, how will you confirm the diagnosis? The confirmation is by ultrasonography, imaging. That is the classical. There are many criteria. The the findings in the ultrasonogram are all described. That is enough. The typical clinical feature and ultrasonogram is enough in 99% of the cases to confirm. There can be other modalities also, scopy, barium, but these are not needed. Other imaging modalities are not needed. This is enough. So what are the other things to be assessed? Of course, vital. The patient can be dehydrated, electrolyte imbalance. So what is very important, when there is a vomiting, what is lost? Volume is lost, so the patient will get dehydrated. Potassium is lost. Hypokalemia. The patient will go in for hypotonia, hypokalemia. There can be acid and chloride loss. So hypochloremic alkalosis. The alkalosis can lead to respiratory suppression and the baby can be apneic. So you need to assess the respiration for apnea, the tone hypotonia, all evidence of shock, dehydration, and there can be potassium and sodium loss also, hypoglycemia also. Patient can be drowsy and can seizure also occur due to hyponatremia. So these are very important because before we take up for surgery and correction, all these vitals to be stabilized. So what is the other thing to be assessed? We need to assess for other medical conditions if it is possible, because there can be vomiting in medical conditions out of which inherited metabolic disorders, inborn errors of metabolism is, especially vomiting, altered sensorium, patient not gaining weight. One of the closest DDs is a medical condition, and sepsis of course is next. And one very important entity is endocrinological, congenital adrenal hyperplasia, where you get genital abnormalities obvious and the patient will be going for dehydration, shock, hyponatremia, hyperkalemia. That is an interesting thing. That's an important DT. And in all cases of an malformation, there can be another malformation also. There are many associations described in the case. So we need to screen for the malformations. Of course, in this case, the stabilization was done, confirmation was done, patient was taken for surgery, and this Ramsey's operation, pyloromyotomy was done. Patient was on ventilator for the next 2 days, and now patient is weaned off and he has started oral feeds. And vomiting is persisting a minimal amount. It may be there for a few more days. Baby is doing fine. We won't go into the theory part of congenital hypertrophic pyloric stenosis. So just rewind and see the visible gastric peristalsis in this case. Thank you.